Welcome to Sticky Med, learning medicine, stick by stick.
Okay, let's unpack this.
Let's do it.
We are diving into a topic that is, I think, part of the common conversation, yet whose biological and neurological complexity, well, often remains hidden. Autism Spectrum Disorder, or ASD. So ASD is defined as a complex, lifelong neurodevelopmental condition.
And the diagnosis, it really hinges on the presence of two persistent categories of deficits. And these deficits have to be significant enough to impact daily functioning.
The first category is those persistent deficits in social communication and interaction.
And the second, that's the restricted, repetitive patterns of behavior, interests, or activities. You have to see symptoms from both.
And maybe the most important word in the name is spectrum. We really need to spend a moment on this because I think it's where most of the misunderstanding lies.
Absolutely. When the sources talk about a spectrum, they are truly emphasizing this massive variation in severity, presentation, and support needs. It's not a straight line from mild to severe. It's much more like a color wheel, where every individual expresses a really unique shade and combination of traits.
So you could have someone who is non-speaking and needs substantial support, and on that same spectrum.
Exactly. All the way to those who are highly verbal, successful, and independent, what people used to call Asperger's syndrome. It really drives home that truth. If you've met one person with autism, you've met one person with autism.
That's a crucial insight. Okay, let's zoom out a bit and look at the scope. I mean, what's the scale of this condition?
Well, what's fascinating here is just the sheer prevalence. The numbers suggest this is far from rare.
Not at all.
The current CDC estimates from 2023 put the prevalence at approximately 1 in 36 children. That's millions of people, which just underscores the need for a really thorough understanding.
And within that huge population, the sources point to a really persistent gender disparity. ASD is diagnosed about 4 times more often in males than in females.
But, and this is a critical nuance, that ratio is likely skewed. It's skewed because females often present very differently.
Oh, so?
They are generally better at what the sources call masking or camouflaging their social difficulties.
So instead of having a visible meltdown, they might just internalize that stress or completely exhaust themselves trying to mimic what they see as neurotypical social behaviors.
Precisely. They might meticulously study social scripts or body language or pop culture references just to appear integrated. And this ability to camouflage means that the diagnostic tools, which were largely developed based on male presentations, often miss ASD in girls.
Which leads to later diagnoses.
Or misdiagnoses entirely. It suggests the true gender ratio is probably much closer than 4 to 1.
That makes diagnosis so much harder, especially when you add in comorbidity. We're not talking about ASD in a vacuum.
Oh, absolutely not. The sources consistently emphasize high rates of co-occurring conditions. Things like anxiety and epilepsy are common.
And there's a huge link with ADHD, right?
A striking link. The data shows that roughly 30 to 50% of individuals with ASD also meet the criteria for ADHD.
Which makes you wonder if the mechanisms that drive attention and social processing are somehow intertwined.
The data certainly suggests they share some common biological ground. And beyond that, a significant portion of individuals with ASD also present with intellectual disability, which is a massive factor in determining support needs.
So to manage all this variability, the DSM-5 uses 3 levels of support.
Right, and this is based purely on observable behavior and developmental history.
Okay, let's break those down. Level 1 requires support.
These are the individuals often described as high functioning. They can typically speak in full sentences, but they really struggle when social contexts get unpredictable.
So they can communicate basic needs, but the nuance is the hard part.
Exactly. Understanding a joke or the unwritten rules of taking turns in a conversation. And their inflexibility, that need for routine, it's present enough that it clearly interferes with their independence.
Okay, moving up, level 2 requires substantial support.
At this point, the core deficits are pretty marked. They're obvious to a casual observer.
So initiating social interactions is harder.
Very difficult. And their nonverbal expressions might be minimal or unusual. Their reliance on routine is frequent, making any kind of change a real point of distress.
And finally, level 3, very substantial support.
This is where the communication deficits are most severe. These individuals may be non-speaking or use very few functional words.
And the rigidity.
It's extreme. Any deviation from routine can lead to intense, debilitating distress. This level really represents the most acute need for individualized, structured care.
Now let's transition into what I find to be the most compelling part of this deep dive, the hard science.
The etiology and pathophysiology.
what causes it, and what's physically happening in the brain. And the big takeaway is that ASD does not have a single cause.
Not at all. It's a highly complex interaction between genetics and the environment.
Mm-hmm.
And the genetics are truly the majority factor here.
How much so?
Heritability estimates are surprisingly high, close to 80%, but we need to be really clear about what kind of inheritance we're talking about.
So it's not like a single gene that dictates your eye color.
Oh, not at all. Far from it. In the majority of cases, we are looking at polygenic risk.
Polygenic, so multiple genes.
Hundreds, possibly thousands of small common gene variations. Each one on its own does very little, but when enough of them add up, they cross a threshold.
That's a fundamentally different model than a single gene disorder.
It is. But you still have those smaller, more specific subsets. We see de novo mutations, spontaneous changes in genes like CHD8 or SIMPHIA3 that aren't present in the parents.
And then there's syndromic autism.
Right, where ASD is associated with a known genetic condition like Fragile X or tuberous sclerosis.
So if genetics provides the vulnerability, what about environmental factors?
The environmental factors act as risk modifiers. They don't cause ASD on their own, but they can increase the risk, especially with that genetic predisposition.
Like what?
Advanced parental age is a clear one, both maternal and paternal age, over 35 or 40.
And the prenatal environment itself?
Yes, things like exposure to certain medications like valproic acid, extreme prematurity, low birth weight, those are consistently noted. And there's the emerging theory of maternal immune activation.
The idea that a severe infection in the mother during pregnancy could alter the fetal brain's development?
Exactly. So if we accept this complex mix of risk factors, let's get into the wiring. What is the leading theory on what's physically different in the brain?
This is what I was waiting for.
The consensus is really focusing on abnormal brain connectivity, specifically something called a synaptic pruning deficit.
Pruning, like in a garden where you cut back branches to help the plant grow stronger?
It's a perfect analogy. In a developing brain, you make way more neural connections, synapses, than you need. Pruning is the natural process where the brain deletes the weak or unused connections. It's neural house cleaning.
It makes the whole system more efficient.
Incredibly efficient. But in ASD, the sources consistently show this pruning process is often reduced. The brain fails to clear out the junk.
And the result?
An overabundance of synapses. You end up with a system that is noisy and inefficient. It's like having 1,000 tiny, distracting side roads instead of a few clear highways.
That brings us directly to the connectivity theory, which is where it gets really interesting, because it describes two contrasting patterns happening at the same time.
That's right. First, you get short-range overconnectivity.
Too many local connections.
Exactly. Too many connections within small, specific brain regions. This hyperlocal density might explain the intense focus on tiny details, or why simple sensory input can feel so overwhelming. The local system is just firing too much.
And the flip side of that local density is
long-range underconnectivity. This means weak or inefficient connections between distant brain regions. So, to use our road analogy, you have amazing local streets within each city. But the interstate highways connecting those cities are all blocked.
That's a fantastic way to put it. And if the interstate highways are broken, that makes integration of information incredibly difficult.
It's the key. For something complex, like reading a social situation, you need to combine input from your auditory center, your visual center, your emotional center, all at once. If those long-range connections are weak, that integration fails.
And that leads directly to the social communication deficits we see.
Precisely. We should also just briefly mention the findings of early brain overgrowth, or macrocephaly, in the first couple of years of life, which then tends to plateau.
Okay, so let's move from that hard science back to the observable reality. How does this all translate into the clinical presentation?
We can use the DSM-5 structure. We start with domain A, social communication and interaction deficits.
First up, social-emotional reciprocity. This is that back-and-forth flow of conversation.
Right. It's the lack of shared enjoyment. A child not pointing at something interesting just to share it with you. It's a failure to initiate, or difficulty keeping a conversation going.
Then there's nonverbal communication. And this is more than just poor eye contact, right?
Much more. It includes a lack of facial expressions, a flat affect, or difficulty understanding subtle gestures. If your world is based on explicit rules, you're going to miss all those silent cues.
And the third piece is relationships.
Which is often the most heartbreaking. It's a genuine difficulty making and keeping friends, and sometimes a noticeable lack of interest in peers altogether.
That brings us to domain B, the restricted, repetitive patterns of behavior. This is where that rigidity really comes to the forefront.
Let's start with stereotype movements. These are the classic self-stimulatory behaviors, what's often called stimming.
Hand flapping, rocking, spinning.
Yes, and also the repetitive use of objects, like lining up toys in a perfect row instead of playing with them imaginatively.
Then you have inflexibility. This is a core feature for so many.
It's that extreme distress at small, seemingly tiny changes. A different route to school, a different plate for dinner. It can trigger immense distress because it breaks the predictable routine they rely on.
And we have to talk about restricted interests.
These are not just intense hobbies. The sources describe them as highly fixated, with an abnormal intensity or focus.
Like having near encyclopedic knowledge of incredibly narrow topics.
Exactly. Train schedules, washing machine parts, you name it. Which, if you circle back to the connectivity theory, makes perfect sense. The brain is optimized for that kind of local, detailed processing.
And finally, sensory processing.
Critical. And it can go two ways. You can have hyperreactivity, being oversensitive, covering ears at loud noises, avoiding certain food textures, hating the feel of clothing tags.
And the opposite, hyporeactivity.
Being undersensitive. This could look like a very high pain threshold or a deep fascination with spinning objects or lights. What looks like bad behavior is often just a physiological response to sensory overload or underload.
So, moving to management. The one thing the research just hammers home is that early intervention is key.
It is the key factor for improving lifelong outcomes. And the approach has to be multidisciplinary. There's no cure for ASD itself.
It's all about maximizing function and quality of life.
Right. And the primary treatment is behavioral and educational therapies. Applied behavior analysis, or ABA, is the most cited.
Which focuses on reinforcing positive behaviors.
And it's important to say that modern ABA has shifted. It's much more focused on naturalistic implementation teaching skills in real-world contexts, not just rote compliance.
And alongside that, you have speech and language therapy.
Which is essential.
Right.
And it often focuses on what's called pragmatic language.
The social rules of speech.
Yes. Understanding sarcasm, knowing what's meant versus what's literally said. Then there's occupational therapy, or OT, which is huge for those sensory processing issues and daily living skills.
And for older individuals, say level 1 adults.
Social skills training can be a really powerful tool. It explicitly teaches the social rules that neurotypical people just tend to pick up intuitively.
And where does medication fit in?
Pharmacotherapy is only for managing associated symptoms. It doesn't treat the core features.
So for things like severe irritability or aggression.
Exactly. You might see specific antipsychotics like risperidone. For co-occurring ADHD, you'll see stimulants. For anxiety, SSRIs are common.
So given that ASD is a lifelong condition, what does the prognosis look like?
Well, it's highly variable, as you'd expect. But the good news is that significant improvements in adaptive functioning are absolutely possible with early and consistent intervention.
And the research is pretty clear on what predicts better outcomes, isn't it?
It is. The two biggest predictors for a more positive lifelong trajectory are the presence of functional language by age 5 and a higher IQ.
So many adults with level 1 ASD are living independently, they're working.
Absolutely. They may still need support with complex social demands or executive function, but they live full lives. The need for support might change, but the underlying neurological condition is always there.